Welcome to this webinar, PSS Life University. Is it Lewy? Recognizing the symptoms of Lewy body dementia. We have Pamela Corsentino and Brandi Hackett. So Pamela is the Director of Support Services for the Lewy Body Dementia Association. She is a gerontologist and a licensed professional counselor. Brandi is a licensed master of social work and a certified advanced social work case manager. She's the manager of support services for the Lewy Body Dementia Association. She's a medical social worker focused in working with older adults and their support system. A little bit about PSS. So we were founded in 1962 as an innovative multi-service agency whose mission is to strengthen the capacity of older New Yorkers, their families, and communities to thrive. This program, which you're all a part of, is a part of our PSS Life University. And we offer educational and other programs online. And our main function of PSS Life University is to help older adults stay healthy, engaged, and connected. Our PSS Circle of Care program, we specifically offer free personalized support for folks who are caring for someone who's frail, chronically ill, or has memory loss, and families where a grandparent or a family member other than a parent is raising a grandchild. Our grandparent family apartments is the first U.S. residence purposely built for grandparents raising grandchildren. Our coming of age program inspires people over the age of 50 to live with passion and purpose, and our 10 senior centers have helped older adults stay healthy, engaged, and connected, specifically playing a crucial role in food distribution during the COVID-19 crisis here that we're all experiencing in New York City and across the country. We welcome volunteers who serve as an important role in delivering our services. And again, my name is Gavin Castor. I'm an outreach manager here at PSS. Please, at the end of this presentation, type any questions or comments into the chat box. We'll respond to as many as you can. And as of right now, I'm going to stop sharing my screen and hand over the proverbial and literal mic to our presenters. So thank you all so much for coming.
Okay. Oh, there we go. Hold on, and pull it up. Got to find it. There we go.
I am able to, or I was just able to see your screen, Pam.
There we go.
Perfect.
Everybody got that?
Absolutely.
Okay. All right, so my name is Pamela Corsentino, again, Director of Support Services for the Lewy Body Dementia Association. And I'm going to start us off, and then Brandi is going to take over towards the end of the presentation. So again, what is Lewy body dementia? So if you look at this slide, you can see that it's actually pointing to a small object there that's actually a Lewy body. So they are actually small little items in the brain. So it's a clump of protein. So some of the statistics on Lewy body dementia, it is the most misdiagnosed form of dementia. And at this time, we're thinking it's about 1.4 million Americans that are affected, mostly adults over the age of 50. We believe that that number is actually probably pretty low because of the misdiagnosis. It is also the second most common cause of progressive dementia after Alzheimer's. So how is it defined? It is a progressive brain disorder. There are abnormal protein deposits called Lewy bodies in the brain, and that's the alpha-synuclein protein. It is named after Dr. Friedrich Lewy, who's a neurologist, and it's actually an umbrella. So Lewy body dementia encompasses Parkinson's disease dementia and also dementia with Lewy bodies. The difference in the diagnostic criteria is based on the timing of the symptoms, and we call it the 1-year rule. So if you develop Parkinson's symptoms 1 year or more before you develop the cognitive symptoms, it's Parkinson's disease dementia. If you developed the cognitive symptoms prior to or at the same time as the Parkinson's symptoms, it's known as dementia with Lewy bodies. So how does it differ from Alzheimer's? So with Alzheimer's, you have mostly prominent memory problems. But in Lewy body dementia, that memory may be relatively spared at the beginning. I've had people say he can't have dementia because he can tell me what he had for breakfast this morning. With Alzheimer's, you have trouble storing new information and short-term memory and making new memories. And then there's a gradual cognitive decline. But with Lewy body, that cognition is fluctuating. So some days they are just as they always were, and other days there is a marked difference. It also targets a different set of cognitive functions, so not so much memory as problem solving and reasoning or executive functioning. Now, with Alzheimer's, the physical symptoms are going to be more pronounced at later stages of the disease, where with Lewy body dementia, those physical symptoms may be present at all stages. And there are also some additional symptoms that are not common in Alzheimer's, such as the vivid hallucinations and the REM sleep disorder. So how does it differ from Parkinson's? So with Parkinson's, you're always going to have movement affected. With Lewy body dementia or dementia with Lewy bodies, you're always going to have cognition affected. So with Parkinson's, you'll have some mild changing in thinking at diagnosis and may later develop dementia. But with Lewy body, you're going to have one or several other symptoms at diagnosis. And you may not show obvious Parkinsonisms in early stage. There are people who really don't show that Parkinsonism at all. So the prognosis of Lewy body dementia. Like Alzheimer's disease, it's very tough to pinpoint. It could be 2 to 20 years. And a lot of that has to do with the fact that it may actually be laying dormant. So it may actually be in the system much longer. And it is not until those symptoms actually show up and they're very obvious that people will get a diagnosis. So that's why we say it's 5 to 7 years after diagnosis. Some of the factors that affect the prognosis of the disease are your overall wellness. So are there any other medical conditions? And then also the quality of clinical care that the person is going to receive. So when you go to receive a diagnosis, what is typically seen? So most people will wind up seeing at least 3 physicians to get a diagnosis. Most will take over a year to get that diagnosis. The majority of the diagnosing physicians are going to be neurologists. Very few are going to be diagnosed through their primary care provider. And the majority of people will also be diagnosed with something else first. Now, what is really unusual is some of the things that people are diagnosed as will also depend on their symptoms, and it will depend on their age. So for those who are younger, if they are having hallucinations, they may be diagnosed with schizophrenia or another mental health disorder. For those who are maybe a little older and their symptoms are more physical, they may be diagnosed with anything from cardiac issues to, I've seen people who have been diagnosed with all sorts of movement-related disorders. There are a lot of barriers to diagnosing LBD. So because the clinical picture is going to vary, so symptoms don't present the same way. So one person may have very vivid visual hallucinations where another person's hallucinations are more auditory, so they hear things. Many people don't report those symptoms. So it's not like the average person is going to go into their primary care physician and say, yes, I'm seeing blue bunnies jumping across my bed. In addition, there's patient insight. So for someone who sleeps alone, they may not be aware that they have REM sleep behavior disorder. For someone whose hallucinations are very realistic, such as seeing, a dog in the yard or a large bird perching on a tree, they may not even realize that they're hallucinating. There are also some clinician-related challenges. Primary care physicians are not often familiar with the complex diagnostic criteria of Lewy body. It's not what they usually think of. Oftentimes, people are not going to get a referral to a specialist. And then without a referral for neuropsych testing, oftentimes you're not going to be able to get that diagnosis. And right now, there is a lack of a widely available biological test to pinpoint Lewy body. Oftentimes, you're going to see a mixed dementia diagnosis. So you're going to have symptoms of other dementias as well, usually Alzheimer's, frontotemporal dementia, vascular dementia. And so sometimes you're going to see symptoms from both, and sometimes you're only going to see the symptoms of the most prominent dementia. That makes the clinical diagnosis more difficult. Alzheimer's is usually seen coexisting with Lewy body dementia. And they found that as the level of Alzheimer's disease pathology rose, so did the level of Lewy body pathology. So they're thinking that there may be some sort of a synergistic effect between the two. So again, these are early findings. Fluctuations. So this is one of the things that is difficult for people to understand about Lewy body dementia. You have these fluctuating levels of concentration and attention. So we have things that they call moments of clarity or showtime. So they are, just like they used to be. They can take on any task, they can answer any question, they're fine. But then you're also going to have these unexplained episodes of confusion, or you're going to have an increase in symptoms. There's also these periods of what they call zoning out, where they're just kind of staring into space. And sometimes they actually lose time, so they don't realize that they've been sitting there staring. And then you're also going to have this excessive daytime sleepiness that will happen. So sleep disorders in LBD are very common. Insomnia is a big one, restless leg syndrome. But the big one is the REM sleep behavior disorder. So what this is when someone is dreaming and you're having rapid eye movement sleep, your body is actually paralyzed. You don't move. And that's why sometimes when you wake up in the middle of a dream, you feel paralyzed. But when you have REM sleep behavior disorder, you're actually acting out your dreams. Now that's just not, kind of moving or mumbling. You are literally kicking a soccer ball or baking a cake or fighting off an intruder. And so this is often seen with Parkinson's, dementia with Lewy body, and also something called multiple systems atrophy. It is acknowledged as a core clinical feature of dementia with Lewy bodies. The prevalence is up to 76%. And it can actually appear 15 to 20 years before the onset of the cognitive symptoms. So some of the movement-related symptoms are going to be what you're going to see in Parkinson's. So the slowed movement, reduced spontaneous movement, rigidity, repeated falls because they're having trouble with balance, slow shuffling gait, slight twitches, a rest tremor, but also the one that is the most telltale is the decrease or change in facial expression. So it's almost like they call it like a mask. So the person does not have any expression. It's just a totally blank face, even though they may be experiencing emotions or excited or happy, their face doesn't often show that. So one of the biggest reasons to get a diagnosis is the reaction to medications. So there's a medication sensitivity, which is called neuroleptic malignant syndrome. So many of the traditional antipsychotic medications, such as Haldol or Thorazine, are often prescribed for individuals with dementia to control behavioral symptoms. These particular medications and others can cause a worsening of symptoms, and it can be potentially fatal for someone with Lewy body dementia. Now, a lot of things that you would not consider are also in that category, such as over-the-counter medications, such as Benadryl, diphenhydramine. There is something called the double effect. So the medications that are used to treat Parkinsonism have a potential risk for increase of hallucinations. But yet some of the medications that are used for hallucinations can cause increased confusion and Parkinsonism. So oftentimes for people, there is a balance of what do you really want to treat. So I have met individuals whose hallucinations were horrible, and so they took medications for that and kind of took that whole Parkinsonism as the side effect. For other people, they wanted to be able to move around and their hallucinations were not that bad, so they took the Parkinson's medication. There are other medications right now that are out there that are being marketed for hallucinations in dementia with Lewy bodies and also Parkinson's disease dementia. Now, here's some of the weird things about LBD that would cause somebody not to get diagnosed. Now, if you look at this list, if you walked into a physician's office and you had every single one of these symptoms, how many of them would say, seems like you might have dementia? Well, the issue is that the autonomic and constitutional symptoms of Lewy body are oftentimes the biggest complaint that people have. So the loss of smell can actually happen years before, and it is a complete loss of smell. Now, the unusual thing is sometimes the sense of smell will return. I've had individuals tell me that that's happened. Temperature regulation, they're too hot, too cold, which can be dangerous if you live in an area that has extremes in temperature. The blood pressure control is such that when they, oftentimes when they stand up, their blood pressure will drop and they can pass out. And so constipation, urinary incontinence, those things can happen early on. Drooling is very, very common, as is a runny nose. So cognition. What's interesting about LBD is that there is forgetfulness, but most of that forgetfulness is due to a lack of focus and attention rather than memory. So it's kind of like if you're deeply engrossed in a television show and someone comes in and they tell you something and they leave, did you actually really hear what they said? Or if they give you a whole list of things to do, are you going to remember every single one of them? So oftentimes that's one of the big issues, and people attribute it to memory, but it's rather focus and attention. Trouble with problem solving and analytical thinking. That's one of the reasons why people will discover there's something wrong. Maybe they have a job in which they deal with a lot of numbers or very difficult tasks, and suddenly they can't do that any longer. Planning and keeping track of sequences. So they have difficulty with multitasking. You know, if they're given a list of tasks, they may only be able to complete one or two, that they kind of lose track of that. Or if they're following a recipe, unless it's clearly in front of them, they're going to kind of blank out at some point while they're doing that. The disorganized speech and conversation, that's actually, we call it word salad. So sometimes the words get jumbled or they can't find a word. Visual tracking and attention. So that goes along with the visual, spatial, and perceptual difficulty. So for example, if you go to put your coffee cup down on a table, you're going to miss the table and the coffee cup goes, you know, crashing to the floor. Or missing the doorway, walking into a home and suddenly not being able to get out. So you can understand why driving would be an issue. If you can't judge distances, driving is probably not a good idea. The construction difficulty, I put that down as clock drawing and block design, only because oftentimes someone with Lewy body dementia can pass a mini mental status exam, no problem. Where they are going to have difficulty is drawing the clock, intersecting the squares, arranging the blocks, because that is a visual spatial. And if you go online and you take a look at the clocks that are drawn by those with Lewy body dementia, you will understand. So the psychiatric and behavioral symptoms of Lewy body. These are probably the most challenging for the average caregiver, because people are just not prepared for the things that occur with Lewy body dementia. So there's the visual hallucinations, but that could be any kind of hallucination. You can hear things, you can feel things, you can taste things that are not there. The delusions, depression, anxiety, apathy, tremendous apathy, and the REM sleep behavior disorder. So I'm going to go into those a little bit more specifically. Hallucinations, again, you are seeing, hearing something that is actually not there. It is completely false. But an illusion means that you're looking at a coat rack, but you see a figure in the corner. You look at the wallpaper and it's moving. So an illusion is a misperception of something. A delusion is a fixed or false belief. So they will believe that someone has been replaced with an imposter, that there are two homes. They have these very unusual delusions, and you cannot convince them that they are not real, because to them they are real. Now, the apathy is more than just, I don't feel like doing something. It is, I missed my granddaughter's birthday. Oh, well, you know, oh, my uncle died. Are they having any food at the funeral? Like true apathy. There is no emotion whatsoever. Now, oftentimes they're aware of this apathy, and because they're aware of it, it makes it even worse, because they feel like they can't help it. Now, often when you're going to see with these hallucinations, delusions, and illusions, is there is a sense of awareness. So it is unlike other dementias in which something happens and then 15, 20 minutes down the road, they don't remember that. You can actually have a conversation with somebody with Lewy body about a hallucination that they had 2 years ago, and they will remember it. The depression and the anxiety. So some of that is going to be the actual disease process. But a lot of it is the fact that you are aware of everything that you're losing. And if you are younger, it becomes a lot more difficult. And so some of it, while it may be biochemical and related to disease, so it may be helped with medication, other times, you know, it really would help if someone got a chance to see someone and go through some counseling to help deal with the changes that are going on. Crisis situations. So this happens very often. Emergency services are called in, either medical services or because of a behavioral disturbance. Oftentimes people will get into situations legally and be involved where they're arrested. You always have to be very careful. So we tell people, if you have a bracelet or something that explains, if you're able to explain to the responders who come, because the first instinct is usually to give the person something to calm them down, usually Haldol. This can be disastrous. And so also the more the flashing lights, the people coming in, all of that is just going to be way too triggering for them, because there is a whole lot of stimulation, and it will just make the situation worse. So to treat the psychosis and hallucinations and anxiety, you want to rule out any contributing physical ailments. Could they have an infection? Are they in pain? You want to review medications, because oftentimes what happens is people get more medications prescribed to them, but it's very rare that they go, oh, maybe you don't need to be taking this. Also, look at the interactions between medications, because sometimes you can have a medication interaction months or years after you've been taking that combination. Environmental or social factors. If you live in an apartment, did the man upstairs suddenly decide to take up tap dancing? I mean, it could be anything. You could have moved the furniture. During this time of the year, moving furniture around and putting up Christmas lights can trigger people's LBD symptoms. You want to try to use some non-pharmacological approaches first, and then maybe consider the use of an antidepressant. When you are using antipsychotic medications, you want to go with an atypical and monitor very closely. So the current treatment strategy that we have right now is to improve the quality of life. So many of these symptoms can be managed or reduced with medications and other therapies, but no treatments are currently available to stop the disease progression. Potentially helpful interventions are going to be physical therapy to maintain balance, gait, strength, occupational therapy to keep someone independent, speech therapy. Often they will have issues with swallowing and also word finding, and then of course counseling. So some of the challenges for the LBD care partners are going to be that the symptoms affect more than cognitive abilities. So there's the motor symptoms, the autonomic symptoms, sleep issues, especially if you're a care partner sleeping in the same room, in the same bed. The fluctuations are going to make daily life challenging. Behavioral symptoms, most people are not prepared for those. Those are very unusual. And the activities of daily living are going to be affected sooner because of those motor and autonomic symptoms. And studies have indicated that caregivers of those with LBD face increased stressors and that it is the most expensive form of dementia. And I'm actually going to turn it over to Brandi at this point.
Good afternoon, everyone. So what can we do? We've talked a lot about sort of what is Lewy body dementia. So let's talk a little bit about what we can do now that we know what we know. One of the biggest things is getting education. And so such as what you've received today, whether it's a basic overview, we have a Lewy line, which we'll talk about in a bit, which gives families much more specific information about what is going on with the situations. Each call is a little different. And so although there are definite patterns like that were mentioned today in the symptom presentation, each family that we support comes with a different set of needs. It's important to know how one is diagnosed. As Pamela mentioned, this can be a very, very difficult process, and families can find themselves often in limbo because the symptoms can appear in so many buckets that it's difficult for families to grasp themselves that this could be one diagnosis, but also for the physicians that are providing care for them. As Pamela mentioned, there are certain medications that are critical and that can cause a worsening of symptoms that can make care and their needs more of a concern. Beyond the symptoms, as we've talked about today, there are a variety of community resources. Our association supports nationally. And so as a social worker myself, sometimes we do have to get creative in what we can share. We are lucky to have a network of nationally based volunteers that can help with more local options, but the resources are different. And if anyone has supported families, every family comes with a different set of financial resources, sometimes logistical resources, levels of family support, and so we do have to get creative. There are treatments, and luckily we are in a space where there's also a lot of research being done, not only in the specifics of Lewy body dementia, but also in other dementias as well as things like Parkinson's disease. And so in this realm, we are blessed that we often share similar information. And as we talked about the physical and behavioral challenges, because it can be both a risk to the person who's affected and also their care providers, it's important that everyone involved, whether that be a person or a professional, is most informed on what can be helpful. Next slide. So what can we do? Teach, 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 educate, educate, educate. We are so glad that you came and joined us today. And so what you know, as you start to recognize symptoms, whether that be in your loved one, whether that be in someone that you know personally, as professionals, if you're supporting someone, being aware of as much as you can know as early as you can know can be helpful and supported. We do know that this disorder is, as Pamela mentioned, frequently misdiagnosed. Not only are individuals needing the education, but our healthcare professionals are needing education. And we're lucky that we have resources of education both for the healthcare professional and for families. When you, as they say, know better, do better. And so as families that are directly affected, or as care professionals that are trying to support families, take that information and make sure that we are advocating. It is all of our responsibilities to make sure that everyone has access to the most up-to-date and most vetted information. And then if there is a diagnosis, making sure that the families that are trying to support know as much as they can know. It's a hard diagnosis to support, and often people can be very private about some of the symptoms that they are experiencing. But if people around the closest in the core are aware, that can be helpful, because then if a crisis were to occur, or if a worsening of symptoms, you're not starting from square one to gain additional support. Next slide. So what do we do as an organization? We do want to be an additional resource so that you guys feel that you have a one-stop shop for both information and support. Next slide. So we are grateful to be a national organization, but to have support and platforms like the organization we're supporting today in education. So we go hand in hand with things with boots on the ground. Because we have such a national stretch, we are well aware of our scope, and it takes partnerships like the one that we have today to make sure that people are getting care on all levels. As an organization, we focus on what you see on the screen, so education, outreach, and research. So it's important for us to be a part of all of that. So we have a scientific advisory council and research point person to make sure that we're staying on top of what's happening specific to Lewy body dementia. We are grateful for funding that is specific for this diagnosis. Education, as we mentioned, it takes all types. So it's important for us to start education on the consumer level, such as these presentations, but also to provide additional educational support for professionals as well. As I always say, you cannot use a resource you do not know exists. So for us, just letting people know that we exist as an organization, and then also letting people know how important it is to know more information about Lewy body dementia and how that can be supportive, because as we all have seen, even people with incredible healthcare support, family support, finances, etc., such as Robin Williams, could not get a diagnosis even though he had quite a few symptoms until following his death. So we want to make sure that we're there not only to support the research that's happening, but also to make sure that we remain very much on the ground floor with those that are directly affected, making sure that those living with Lewy have a place to go and have an organization that understands where they're coming from. Next slide. So what type of services do we offer? Pamela and myself help to support all the resources that you see on the screen. So as I mentioned, we have a Lewy line, which is a helpline, not a hotline, that provides direct support to families that are affected. And you can see you can reach us by toll-free or by email there. We can share information after. I think Gavin mentioned he was going to share a couple links following our presentation. We also have support groups. We have a national network of support care facilitators that we train as an organization to provide support groups specific to those that are affected by Lewy body dementia. We also have online communities such as closed Facebook groups. Pamela leads an online support group for those directly affected by Lewy body dementia. And then again, we also have an incredible network of lived experience volunteers to support our families. Next. We also offer webinars like what you are attending today, again, both for professionals and for communities. Next. We also have a tremendous amount of wonderful vetted publications on our website that you can find at lbda.org. So there's, I would say, the majority of our publications are available both electronically and in print. We also have special care packets for those that are newly diagnosed that we can mail to their home if requested. Next. Again, we have a lot of downloadable materials that are there on our website. We have a new website, which is a little easier to navigate. So if you're coming to us today as a healthcare professional, you have a tab just for you. If you're coming to us as a care partner or as a person directly affected by Lewy body dementia, we have tabs just for you as well. And so on our website, we have great, very usable materials such as the diagnostic symptoms checklist that you see on the screen. This can be a very, very helpful tool as families are trying to get just an awareness of what's going on with their loved one, and also to put what they're seeing as symptoms in one spot. So when they have conversations with their healthcare professionals, they're able to organize their thoughts prior to those meetings and appointments. Next slide. Also, care briefs. These are topic-specific snippets of articles that are also available. So if it's something where a person just wants brief information about a certain topic, such as sleep, behavior, polypharmacy, we have those on our website and can share those readily. Next. Again, focusing on our connections to research centers, we do have quite a few across the United States. You can find those on our website under the research tab. These are organizations, universities, and medical practices that are leading the research in the fight against Lewy body dementia. So this is often how we as an organization can connect those that we serve back to very active research that's going on. And as many of you know, research isn't always physical. So they might be lifestyle-based studies, and it might be for the care partner or those directly affected by Lewy body dementia. So we want to make sure that we have the most up-to-date information where we can share those with not only our support group facilitators, but also to those we serve. Next. It is important for us to stand behind the research. And so we are constantly trying to connect to new research that's coming, and also to be informed about what the research is teaching us. So in the point where we can reattend conferences in person or virtually attend them now, we are staying as up to date as possible on the research that's happening, and again, the research that has happened that we have results from. Next. Also important for us to all be advocates, as we are, it's going to take all of our voices, honestly, but for us, it is important for us to know how we are affected in legislature and how we are making sure that we are staying on top of protecting our families separately. There's a lot of laws that are sort of for global dementia, but we know, and you know now from this presentation, that the needs of those that we serve can be very specific, especially affecting younger ages that sometimes are not protected as well through some of the laws that are currently in place. So we want to make sure that we are on the front lines in working with the advocacy that needs to happen on the government level. Next slide. So being a nonprofit, we also provide community fundraising events where those that are directly affected or those that have been affected that want to give back, whether that be organizing a virtual event. We've had all types from cooking classes to 5Ks and everything in between. But those that say this cause matters to me and we want to do what we can to help raise funds. We also have a lot of virtual platforms now available for fundraising as well. And if there is interest, we can definitely make those available to you. Next slide. October is Lewy Body Dementia Awareness Month. So we just had our fall appeal, actually featured a family here in Georgia where our corporate office is located, who was directly affected. Her mother was affected, and some of the struggles that she had in placement and increasing symptoms, and some of the concerns that she faced as a daughter. So we want to use these months to make sure that we are bringing awareness to the dementia itself, and also to the needs of our community that we serve. Next. So we'll close with this. So this is our contact information. We are both very available. Those are our direct lines. Like I said, also you can reach us through the Lewy line, which is a number that will be shared following this presentation. We just truly appreciate your attention, and I think we do have some time for questions. We're going to both come back up on video, and we'll be available if you have questions. Okay, Pamela, we do have one question. What are the causes? Is it hereditary? I think you're on mute still, Pam. Yeah.
There we go. That's actually an interesting question, because there is a genetic component, much like Parkinson's. So the same type of genetic component. There are studies being done currently to determine the level of genetic involvement. On an unofficial side, I will say that I do know of many families in which there have been multiple generations that have been impacted by LBD.
Another question that we have, which I'll answer, someone is asking if our slides are available. They are not. However, if there is any specific content that you are wanting from the slides, often we have those available through our publications that we can share. You can feel free, I will put my email in the chat, and you guys can feel free to reach out, and I can help connect you with the publications that we do have available.
And I just saw there was one asking about women, and yes, women do get LBD. There is a tendency to see more men, much like in Parkinson's. Sometimes it does present a little differently in women, but I will tell you that it does impact women as well.
What kind of tests are used for diagnosis?
Well, there are some biological, so you can actually get some people, there's PET scans and other scans that are done in addition to some other tests. Oftentimes it is difficult to get those tests, and insurance does not want to pay for them. I always recommend to people a neuropsych exam, a neuropsychological assessment, because of the fact that what it does is it will show what levels of cognition are impacted. So even if you're looking at the physical side and you're looking at the Parkinson's and you're trying to get that diagnosis, you want to know what your level of cognitive functioning is. And it almost is beneficial because it serves as a baseline as well for you to determine.
Pamela, just to follow up on the how might it present differently in women?
So it's kind of unusual because oftentimes with women, our brains are different. And so again, this is somewhat unofficial. This is more observational on my part. I have found that women's thought processes and the way we process information are different. And so when the LBD symptoms present, the hallucinations might be a little bit different. The actions might be different. So while the apathy level might be here for men, sometimes for women it'll be a little bit different because we have a more emotional guilt. I know that sounds terrible, but there is that I should be feeling this and what is wrong with me. So they pick up on it a little bit more. Women also tend to notice their symptoms sooner, but they also can really cover much better.
Someone had also asked, can someone have most of the physical symptoms, but almost none of the cognitive and psychiatric symptoms? And I would say typically that would be seen more as a Parkinson's as opposed to LBD, correct?
Correct. And also sometimes those symptoms aren't noticeable. So you may have cognitive difficulties that are so minor that you're just naturally, kind of skipping in time to keep up with them. So it could be something as simple as, you went to the store and you forgot 2 items. So that actually might be part of the symptoms, but because it just seems so minor, you're not even considering it.
There is a very specific medication question. Does Aricept have any effect on LBD?
So that's actually a very good question. The medications that are used in Alzheimer's, so the Aricept, Namenda, Exelon, and I usually just say the actual brand names because it's easier for people, they have a tendency to work fairly well in LBD. And that is because they work on cognition. They don't work on memory. And because memory is pretty much spared, especially in the beginning, people who take them have reported it helps to clear things up. They have better focus. It helps them kind of sequence things better and to feel more on track.
There's a couple back-to-back questions. The clarification, are you stating that Parkinson's and LBD both present in the same person? If so, what percentage?
So you have no idea what the percentages are going to be. So you can actually, it's Parkinson's and dementia with Lewy body. So if someone has Parkinson's disease dementia, they're going to have Lewy body dementia. So for some people, their physical symptoms are great. Like they have full-blown Parkinson's and then they have the dementia aspect. For others, they may have some Parkinsonism, maybe an occasional twitch in their thumb. They may have a little shuffling sometimes in their gait, or maybe their speech is getting a little soft. But other than that, it's mostly the cognitive symptoms. And that's one of the reasons why it's so difficult to diagnose and to treat, is because you don't know what those percentages are going to be. They can change, and it can depend on the person's stress level. It could depend on whether or not they have eaten. It can depend on all sorts of things as to which symptoms are showing up.
There was more follow-up questions to the differences between men and women's brains. They were asking for any specific research, or is that what you're seeing anecdotally?
For me, that is mostly anecdotally. As far as I know, there isn't any deep research on LBD and women and men. I do know that oftentimes it's not teased out because LBD research is so new right now comparatively when you look at Alzheimer's research. But being kind of a neuro nerd, I would love to see if there is actual research on that, because I do know that women and men have very different brains, functioning wise, but mostly a lot of that also sometimes has to do with experiential, because we experience life much differently. Our brains react much differently to things.
I can tell you from calls that I've taken on the Lewy line that and I don't know if it's just the description that's provided to us, because often, we are not the medical providers of the individuals that call. We are very clear with that. So we are getting their version of the story and the version of the story they want to tell us. But I can tell you, even in some calls I've had in the last week, that the females that were presenting, the hallucinations that were described by the family were much more relational. So they were involving people, sometimes deceased relatives, sometimes certain pets, where I have found in general that when I'm hearing about a gentleman's hallucination, sometimes it is involving objects or things. And again, not exclusive, but I can tell you that it's been interesting to hear certain things that are being said, in a sense, again, anecdotally, no research on this, but it's been interesting to noticing the patterns there.
Well, and you see that oftentimes if you're in community care and there is a female with dementia, she's often worried about getting home to cook dinner. Where am I have to get my child off the bus. And then when you have a male, oftentimes his concern is job related, or it could be service related if he's a veteran. And so just in that way, there's a little bit of a difference.
What other questions do we have? I'm double checking, but I think that we have addressed the ones that came through Q&A and also through chat. I think we have a couple more minutes left if there are other questions. I feel like we need some hold music or some Jeopardy music between the questions.
So once again, I will tell you all, we do have our Lewy line, which is a helpline. We also have a number of Facebook groups. So our Facebook group are actually, we have one that is solely for care partners. And then we have another one that is solely for those who are living with the diagnosis themselves. And then we have one that is actually a combination. So it's for those who are earlier on in the disease process, who are a little bit more independent, and also their care partners. And the reason why we created that is to foster a sense of understanding between care partners and those who are diagnosed, and also to promote independence, because sometimes the care partners will be on the page of the care partner page, and some of those posts are pretty intense. So when you're first starting out and you're hearing some of the things that people are going through later on in the process, it can be very overwhelming. For the group that we have that is living with Lewy, we do have a weekly Zoom support group. We've actually had that been going now for over 2 years, and it meets on Wednesday afternoons. And sometimes, I mean, I can get up to 16 in that group, and it's really been very helpful for people. They get to talk to others who are on the same journey that they are. One of the things that we sort of mentioned is that we do have support groups. So right now, of course, our support groups are virtually based, but we have support groups nationwide, and we also educate support group facilitators. So if you are someone who has a current dementia support group and you would like more information on LBD, we can work with you and then be able to list your group on our site. We also have a number of groups that are volunteer-based as well. We have groups that are for care partners. Those are for those that are for living with Lewy, and then some that are dyad groups. So it is both members of the dyad, of the care partner, and the person who's diagnosed sitting in the same group.
I did want to mention we did have one comment I did not draw interest to, but it was just referring to how antipsychotics truly can greatly negatively affect someone with LBD, but they we're talking about living in a community, in a memory care home, and that the family is insisting on a very specific kind of medication, and the neurologist and psychiatrist are sort of in discussion with what that is going to look like. Again, not being someone's medical care provider, what we do as an organization is we provide additional information. So we have a medication glossary that's currently under review that provides medication-specific information. We have the care briefs that we mentioned in our presentation that can be specific to some of the needs that we have. We have a scientific advisory council. So if it's a new medication or something that comes in that we want to make sure that we have the most up-to-date feedback on, we're able to ask them. So to be able for them to provide additional information to their healthcare provider. Again, we are not the last word, because as people are coming to us, they have a variety of what they call comorbidities or other things going on. They have financial resources, they have certain health insurance, they have other supports and other needs. Most of the time, a Lewy body dementia unfortunately does not live in a diagnostic vacuum. So they're also supporting a host of other things that are going on, which could be physical concerns and diagnoses, but also mental health concerns, both chronic and critical needs that are happening. And so it does take the expertise of the care providers that are there, boots on the ground with families. But what we try to do is provide additional information to share with those care providers so that the decisions are as informed as possible when it comes specific to their diagnosis and the meds on how that they interact specifically with Lewy body.
Another thing that we always caution people about is anytime you're going to have something such as a major procedure or a surgery, that it could negatively impact the person and accelerate symptoms. So you want to be very clear with the anesthesiologist and the surgeon that this person does have Lewy body, and to be aware of that, even something as simple as a dental procedure. So you have to be very much aware of that. And the delusions, I mean, they're out there. I mean, we have had some, I mean, I guess Brandi coming into this now for the last 2 months has been hit with some of the things, and she'll say, okay, so we have one now that sees, there's worms in the food, or another one that thinks, his wife is an alien. And so to us, this is just, just another Tuesday, because we really kind of understand that this is normal. But for a care partner, this can be very upsetting, and it can be very, it can set you off balance, because you don't know what to expect from one day to the next.
Yeah, and especially if those delusions and hallucinations are in direct effect of that relationship. I know just one, again, I spoke to recently, part of her hallucinations involved her daughter who had died. And so every time that she would have these open conversations with this daughter, and her husband was in the room as her care partner, it was constantly upsetting to him because of just his own grief involving that loss. So even though it was providing her comfort, even though she now had a regained relationship with her daughter, the fact that it was not a upsetting hallucination to her to have regained that, it was very much to him upsetting. And so finding the balance in making sure we're treating hallucinations appropriately, but then also supporting the care partners as they're directly affected. So we are closing in on the hour, so we truly appreciate all of your attention, your questions, your attendance. Please do know that we're here for a resource for you guys and for the families that you serve, if you're a professional, and also for individuals that are listening in on this call. We just truly appreciate PSS and giving us the opportunity to be here as a platform. And Gavin and team, we're going to turn this back over to you guys.
Thank you so much, and thank you so much for your presentation. Again, I want to follow up and tell everybody who's attending that I will be relaying the appropriate information that our presenters are giving, including access to their helpline. I want to, again, say thank you to our presenters for their information, and I hope everybody has a safe and healthy week. Thank you all so much.